Hello, good evening everyone. Can you all hear me? Any problems hearing, let us know. Welcome to SOWRA Sessions, and this is the first webinar in a series that we're hoping to bring you this year, detailing regional techniques over a series of common operations that we might all come across. So welcome and thank you for joining us. Bear with us, this is our first one. The technical details in this and things might just need a little adjusting. So introducing you to the team, we've got Dr. Max Byrne, he's our anaesthetic registrar and model. We have Dr. Sam King, who's our regional fellow and IT executive producer behind a wall of many screens over that side. I'm Jo Wilson, one of the consultants here, a regional anaesthetist, and enjoy having an awake upper hand list regularly. And then this is Dr. Matt Oldman, who I think most of you might know, some of you may not. As you know, he's a real enthusiast and expert in regional anaesthesia, particularly with educating and clinically applying it, teaches internationally, etc. But we won't make him blush. So thank you.
Hot enough in here.
Yeah. Today we're going to go through awake hand surgery, as you know, and you've seen already the series that we're hoping to bring you. There will be more if it works out as a good platform for us to deliver these. We're going to use Slido, which there's a QR code that's coming up on your screen now. If you could use this to ask questions, then we can just collate them a bit more easily and not miss any, which we might do in the Teams chat. If there's anything you see already that's being posted that is a question you'd like to know, you can give it a thumbs up and it will kind of push it up the order of the sort of preferences. We'll do this in two parts. We'll talk about the proximal part of the awake hand surgery and then pause for those types of questions, and then we'll have another set of questions at the end just to kind of break it up a little bit. Have I covered everything? Is there anything else we need to do? Great. So let's start. Why is awake hand surgery getting more common, or why is it popular as a thing to do?
Well, I mean, there's a number of reasons. First of all, probably the biggest factor that's increased popularity is ultrasound has made it just so much more accessible for people. Everywhere has machines now. There's lots of resources out there to teach people. Education has increased, and for once, going back to when I started training, regional anaesthesia was the domain of a few experts who could master nerve stimulation and the vagaries of paresthesia techniques and things like that. And if you didn't know how to do that, it was a real art. Whereas now we can see individual patient differences, and our blocks that can therefore become more reliable. So ultrasound's made it more reliable, and hence people are more willing to try it. There's also an element of patient choice nowadays. Some patients expect to be offered a choice, and certainly all patients, where possible, should be offered a choice as part of the consent process. It's very hard to say, for hand surgery, other than you not having the individual skill to do it, but that it's not a technique, a way that they could have it done. And so we should strive where possible to offer that. And then there's benefits, obviously health benefits for some patients, though if you're a fit and healthy 21-year-old, it probably doesn't apply, but for some of our less fit patients, it's obviously less risky. And then there's efficiencies. So whilst it may take us a few minutes to do our block at the start, then at the end, we can reap the rewards. So patients don't need to be woken up. They can bypass first stage recovery, go straight to second stage and be treated like a local and go home. And so that's something you can sell them as a benefit. And also it's quite nice for some patients, have a curiosity about this, and that they might want to see what's going on with their procedure. Surgeons may want to talk to them about it as well. So there's lots of factors, and it'll depend differently on each individual patient and where you're working as well.
So thank you. So how do you approach talking to a patient about how to anaesthetise and awake hand surgery? Have you got a particular way of doing that?
Yeah, sure. So I think most of our patients come, unless they've been pre-warned, which some of our surgeons do, and that's often helpful. but they come in expecting a general anaesthetic. So you're starting on the back foot from the start, really. So you've got to give them a choice. And so I start with saying there's a couple of ways we can do this. Option one is a general anaesthetic, and that's what they're expecting to hear. As I say, alternatively, we can do this under what we call a block, which is where we're going to numb your arm. And I then explain that that's different to surgical local, because often they've been told they're not having a local, they're having a general anaesthetic, and so they will potentially be a bit resistant to the idea of doing something that the surgeon didn't specify. And you've got to tell them the benefits and then some of the realities of it. So the benefits are they'll be potentially through the system a bit quicker. It's not for everyone, you've got to tease that out. And the thing I've learned over the years of offering this is that as many people, if you could think that they're going to want a general anaesthetic, you could be wrong probably about a quarter of the time, and actually if they're offered it, they'll choose to have an awake procedure. And then tell them benefits, tell them what will happen, tell them what to expect, what they'll hear, what they'll see, because those are common anxieties people have. They're worried they'll see the operation, they're worried there'll be noise, and you can pretty much easily allay that and give them some options for that. And then I'll tell them about the practicalities of things like tourniquet, what they might feel. They'll still feel some touch in their arm, but that we'll check that it's numb beforehand. So, what you don't want to do is to talk someone into it who's really not loving the idea. And I'd rather give them a general anaesthetic than try and nurse someone through a case who's terrified. But and the other thing is unpicking sometimes what they've been told by other people. So quite commonly, you see someone who's there with their spouse and they go, the spouse goes, oh, well, I wouldn't want that. I would. And it's not their decision. It's a case of unpicking all of that. So give them a choice and a good reason to do it, and some will choose for it.
Excellent. And so if we were to talk about kind of what block would you choose? So we've got a slide that sort of goes through that.
So my preference, wherever possible, for awake hand surgery is or wrist surgery is I prefer to do an axillary brachial plexus block. There's a number of reasons, some of which are sort of anatomical, and some of which are block related, and some of which are just the fact that it's a very reproducible way of doing things in most people. First of all, for the less fit patient, in terms of things like phrenic nerve block and pneumothorax risk, you'd have to be very unlucky or candid to block either of those things, or to give someone a pneumothorax doing an axillary brachial plexus block. It's also generally possible to perform in obese patients, perhaps a bit more so than an infraclavicular block or a supraclavicular block, which are probably our two alternatives. In terms of anticoagulated patients who are still taking warfarin or DOACs, you can still do axillary brachial plexus blocks on these patients. It's a compressible site, and where there's a risk benefit to doing so, whereas you would feel perhaps less keen on doing that with an infraclavicular block or a supraclav, which is not necessarily so compressible. All of these blocks will block the arm enough for the tourniquet, and none of them will block the intercostal brachial nerve, which is not a branch of the brachial plexus. So you need to supplement that separately. That comes off T2, and so we need to block that separately. And the most convenient place for us to do that is actually in the axilla. So if we're going to go in the axilla to block that, then why not do an axillary brachial plexus block? You do need to be able to abduct the arm, and so that will rule a small minority of patients out. And then for me, the real advantage is, what if something hasn't blocked that well? We can pinpoint it exactly. So we're dealing with the terminal branches of the brachial plexus. So if I've missed a bit, I know exactly which bit I've missed, and I know exactly where in the arm I can then top that up. With more proximal blocks, the sort of retained motor function and sensation they get is much more mixed, because you've got a block that's missing at the cord level or the trunk or division level. And so they get a much wider spread, and then knowing exactly where you're going to go in to target that to block it is much more difficult.
Yeah.
So, and if we then look at this comparison of axillary brachial plexus blocks with other techniques, essentially there is very little difference in all of the techniques. They all come on pretty much equally quickly. It's maybe slightly quicker to perform an infraclavicular block than an axillary brachial plexus block. I don't think 1 minute is particularly clinically relevant. And then, you know, the conversion rate is no different. Tourniquet tolerance is the same, and patient satisfaction is the same. And also this is a plan A block. So this is a block which everyone coming through the training system should hopefully be equipped to do. And by doing the same thing, you know, many times, you become hopefully good at it, and you recognize the sonoanatomy. And so there's it's also, and obviously for teaching purposes, it's quite good as well.
Yeah. So how would you then set up your anaesthetic room? How do you find it works for you for this block?
So I like to stand at the head. There are a few people that like to do it from sitting down. I personally not a great fan of that. So I stand at the head with the arm abducted onto a table. You want to be ergonomic. So here we've got our ultrasound machine directly opposite us. So our hand and our needling, we're all in line, comfortable height. And this puts the arm in a good position, not only to do our brachial plexus block, but we can also then do our distal blocks following on for that. Because normally in my practice, I would use a proximal block with a short acting agent supplemented by longer acting distal blocks. So yeah, I like to stand like this. The other sort of practical tip I have is most anaesthetic rooms, if you're going to do it in an anaesthetic room, then there's normally one side which has less clutter. And normally in our rooms, it's the side with the cupboards, and the clutter is all on the side of the anaesthetic machines and TEVA pumps and things. So I just spin the trolley, so the arm is always out this way. So it might mean that I'm just, you know, might end up having to face that way to do the block, still at the head end, but just spinning the patient. So that just is a practical tip that just helps make things a bit less cumbersome when you're doing the technique.
I've certainly found I have less spaghetti having done that as well. So I think probably, can you show us how you'd scan and go through? And there's Max is obviously part of a anatomical variation, which we'll show you a slide of in a sec.
Yeah, so we now switch to the ultrasound. So my probe is just going to put a bit more depth on because I've dropped that down. So we're putting our probe into the axilla, and it's angling slightly into the axilla so that we get this view here. So down at the bottom of the screen, you can see our humerus down here, and up here you can see some vessels, big vein, our pulsatile axillary artery, and then there's a number of other structures around. The most important one at this stage is this line, hyperechoic line along the bottom, and that's the conjoint tendon. It's the conjoint tendon of lat dorsi and teres major, which is an important landmark because it's effectively the hard deck for our axillary brachial plexus block. So everything has to sit above this. And if we move more distally, say just to here, already we can see some structures here, which is actually the radial nerve, starting to move down towards the humerus. So we risk missing those if we don't block them at the right level. And if we block at this level, everything is generally orientated around the artery in a fairly consistent orientation, which perhaps we can just go to now. So there's kind of 4 common patterns you expect to see. These top 2 are the most common, and they are where the axillary artery is in the center of the screen, and then you have a large vein. You have a separate musculocutaneous nerve in between biceps and coracobrachialis, and the median nerve just above anterolateral to the artery. The radial nerve sat down on the conjoint tendon, and then the variance is in whether the ulnar nerve is above or below one of the veins. The other 2 sort of more minor variations are where the musculocutaneous nerve hasn't yet left from the median nerve. So they both originate from the lateral cord of the brachial plexus, and you can imagine a scenario where they take off late, and this is what happens. And so why it's important to know this is that if you can't find the musculocutaneous nerve where you're expecting to find it, you need to go looking for it in that area. So if we now go back to look on Max, we can see he's fairly classical. He's in the majority. So we have, as we say, we've got our biceps, our coracobrachialis. And in terms of nerves, the most obvious one here is this structure here in between these two muscles, which is our musculocutaneous nerve. We can scan back up and watch it moving towards the plexus, the rest of the plexus. But you can see at some distance there, it's probably about 1.5 centimeters away from all of the other nerves. You can see that if you didn't specifically target that, you might well miss that. And that's where axillary brachial plexus blocks have always had a bit of a bad rep with the landmark technique, because they would potentially miss this nerve. But with ultrasound, we can see it and we can block it. So then moving more around the artery, we can see immediately above the artery, there is a slightly hypoechoic structure with a hyperechoic syringe, which is our median nerve, which is here. And then just to the left of it, there's a little structure here, and that's the median cutaneous nerve of the forearm. And then both of those, and so I'm just scanning just to try and get you to see them a little bit clearer, just changing my angle of incination there. There's a little tip I like to do, which is to come in over the top of these when my needle comes in, just under the prebrachial fascia, and bring my needle right past them and inject some local. And that just helps improve the view of these two nerves so that we can see them a bit more clearly to move around them. So we've got the median nerve, we've got the musculocutaneous nerve, and then we're looking at the ulnar nerve. The ulnar nerve is below this big vein, which I'm blotting here. And if we move the pointer over, that's our ulnar nerve there, just tucked underneath by the side of the artery. And so we can imagine we can potentially get to that from either coming past the median nerve and under the vein, or from underneath. Okay, and that will depend on the patient and a number of factors when you're actually performing the block as to which is the best way to achieve that. And then just underneath the artery in sort of the 6 to 7 o'clock position, there is a hyperechoic structure sat on top of the conjoint tendon, and that's the radial nerve. You can see to the right of it, there is a sort of black hypoechoic structure, which if we put the Doppler on, you can see is a vascular structure. So we would need to be very careful not to accidentally harpoon that on our way in towards the radial nerve.
Where would you find how would you find you sort of access the radial nerve?
Yeah, so to access it in a scenario like this, I would come down. And so first of all, the reason we do the order like I've sort of described is because I need to know where the musculocutaneous nerve is, so that when I bring my needle down here, I'm not going to hit it inadvertently. So it helps to have found it first. So I would bring my needle down here to get to the radial, and I would come just to the side of this vascular structure onto the conjoint tendon. And then we can use the conjoint tendon to funnel local anaesthetic for us, and funnel it proximally up into the axilla. And that will then enable us to open up a space for us to then move our needle, usually underneath this vessel, and then to get around the radial nerve. You can also sometimes potentially sort of come between these two structures, depending on where they are, but it is a bit of a high risk strategy, because you could go intravascular. So those are the main nerves, and then there are some other things we're interested in, which are the cutaneous nerves, which are the intercostobrachial nerve and the median cutaneous nerve of the arm. And they're quite hard to see, but they live in this area up in the tail of the axilla, this kind of area here. Okay, so they may not be blocked by spread of local anaesthetic, depending on the volume you've used. So if you see here, I think you can see just this structure here is probably the most obvious, and that is probably the intercostobrachial nerve. And then I can only see one at the moment, but sometimes there's a pair of them. There's something just here which looks a bit like the median cutaneous nerve of the arm might be there. So I would look to put local here and here, and just get around all of this.
You just deposit, if you can't see it, just to sort of deposit in the area
Yeah.
and tail. Yeah.
And to do that, we've got to get there. And so there's a number of ways we can do that. It depends really on what we've opened up, the space we've opened up with our first passes around those other nerves. So potentially I might come between the median nerve and underneath the vein to get down here, okay, over the top of the ulnar nerve. So my needle would sort of be coming through here and then up here. Or we might come underneath the artery, underneath, getting up here, and then flattening out and getting our needle up here. That, with the angle of this, it looks like that would be quite difficult. And sometimes, even if it's all really, really impossible, we can just do a separate skin puncture just over here and bring our needle in down onto this zone. Okay. So there's all of those nerves potentially need to be blocked. We'll talk about volumes and stuff in a minute. But
I think we've got a video that you've done, and you know, Max has not been harmed in any of this. This is somebody separate, but we'll cut to a video and Matt will explain what he's done to block this patient.
So, as I said, first pass is going to be towards the muscocutaneous nerve. We're approaching the nerve tangentially, so we're not going to risk impaling it, and we're just going to put about 1 to 3 mils around it, just depending on the spread. It's quite a good idea just to tell the patient they might experience a little bit of a pain in their biceps as you do this. Just as you injecting around that nerve, it gets a bit of pressure. And now I'm coming over the top of the median nerve and the median cutaneous nerve of the forearm underneath the prebrachial fascia, and we're just putting a mil of local anaesthetic. And hopefully you can see there just how those nerves shine a bit brighter for having done that. So you can see the first one was the median cutaneous nerve of the forearm, and the second one was the median nerve. I'm now just coming between the artery and the median nerve, just releasing the scanning pressure as we do that so that the needle can easily pass between the two. And now we're hydrodissecting our way around the median nerve, just a couple of mils. I do the median nerve as the second thing to block because it often takes longer to block than the other nerves, and so you want to get your local there first. Now we're going to come over the top to get to the median cutaneous nerve of the forearm, and we're just going to pop through a little bit of fascia here and inject around the median cutaneous nerve of the forearm. Just needs a mil or so. And this is going to provide cutaneous coverage of the medial forearm. And now we're going to come down to the radial nerve at the bottom. So again, a needle trajectory, which is hopefully going to avoid that muscocutaneous nerve. And we're just going over the top of that vascular structure that I showed you. And again, I'm coming down onto the conjoint tendon and using the conjoint tendon to funnel the local anaesthetic to the side. I'm probably a bit deep there. So now I'm going to withdraw the needle a little bit. So I can see the local is now spreading better around the radial nerve. And, you know, not huge volumes, but we're looking at sort of 3 to 4 mils or so per nerve. Just wanted to see enough local anaesthetic getting around them. And now I'm going to come over to the ulnar nerve, which is I'm going to get to by coming between the median nerve and the brachial artery, or axillary artery. So we've got a bit of space here now, and you can see the nerve is just ahead of us there. It's showing up a bit better now. And we're just again coming over the top of that nerve. And again, a few mils of local anaesthetic around it. You don't necessarily need circumferential spread, but it certainly makes you feel a lot happier when you do get it. So we can see that nerve is nicely surrounded. And then having got quite a good angle there, I'm going to go up into the tail of the axilla to look for those cutaneous nerves. I think this is the median cutaneous nerve of the arm that I'm looking at. There's a little pop there as I go through the fascia. And you can maybe, with the eye of faith, make out something hyperechoic that's highlighted. In fact, there's two little structures there. So one of those could be the intercostal brachial nerve, and one of them could be the median cutaneous nerve of the arm. And I think that is the end of that. Oh no, I'm going back for more. So I think this is again to get the intercostal brachial nerve. There's a structure, something I must have seen just down here. Yeah, just on the just above the conjoint tendon. Something I thought looked suspicious down there. So I'm just getting some local anaesthetic around that. And again, with the eye of faith, you can just see a little something there that's a bit hyperechoic as a result of doing that.
Great, thank you. We were talking about volume. So what kind of local anaesthetic would you use here? What's your choice and the volumes that you would use?
So we're going to
There's another slide.
Generally, I'm going to draw up. So I use 1.5% lignocaine with adrenaline because I'm doing this as an awake block. Now, clearly, if you're doing a long-acting block, then you can use whatever long-acting agent you like. But my preference is to do a short-acting block proximally and then do some long-acting blocks distally to provide post-op pain relief. So people have, looked at the minimum volume that you might use, and for sure you can use, a mil of local anaesthetic, which will come on within about 5 minutes to perform a block, and that's O'Donnell's group. They're doing that, and that's all very clever, but it's not a real world solution for most of us. No. Again, this other group, Harper, looked at the volume needed to circumferentially spread around all of these nerves, because that's what we kind of do in practice. We like to feel that we've surrounded all of the nerves adequately. And again, you were looking at sort of 2.5 to 3.5 mils per nerve, which gives you about 11 mils total they use to achieve that. It's worth noting that using that volume, 47% of their patients needed some form of supplementation, whether that was either a top-up block or local from the surgeon or some IV fentanyl. So that's not ideal. And obviously, if you use a bigger volume, you might expect to get perhaps a bit better success rates than that and better duration. So if you then factor in that 11 mils and you add in my 1 mil I like to put over the top, and then some local around the cutaneous nerves, which weren't mentioned in that study. So the cutaneous nerve of the forearm, the intercostal brachial nerve, and the median cutaneous nerve of the arm, we get a real world volume of around 20 mils. And so allowing in a bit extra around everything for cutaneous, for awake surgery, we're looking at between 20 and 30 mils. And I don't think there's anything to be embarrassed about by using that sort of volume, because for this patient, this needs to work. And so if you've got the volume, you've got the safe volume to use, then you should use it. Clearly, if you've got good spread around everything, then call it quits. But this needs to work, and there's no prizes at the end of it for having, loads of local left in your syringe if the patient doesn't have a successful experience. So that's what I draw up, and that's going to factor into that will then depend on what I'm using distally. Again, it will depend on patient weight, and the real challenges are the sort of 50 kilo patient where you've not got a lot of volume. But those nerves all still need surrounding, and they all still take 1 to 2 to 3 mils to surround. So you end up quite stretched.
And it's 1.5% lignocaine that you use.
Yeah, that's what I grew up using. That's what a lot of places use for awake surgery. That's what we use in Canada. So that's something I brought with me from Just Use. It's got more potency than 1%. Obviously 2% would be better, but then there's a volume issue. And we use adrenaline for two reasons: one, to slightly prolong the duration, and two, obviously to give us the safe working volume. So we're working on 7 milligrams per kilogram with adrenaline. And so for most people, 70 kilos or so, that's going to give us a decent working volume. In terms of duration, lignocaine with adrenaline, the adrenaline takes lignocaine from being a short-acting agent where it lasts 1 to 2 hours to being an intermediate duration drug. So sort of typically 3 to 6 hours here in this study, using 40 mils in the axillary. I mean, that's a big volume, but that was typically between 3 and 6 hours. And again, from that, the sort of fairly minimum study that they were using, the Harper study using distal circumferential spread, they were getting sort of between 2.5 to sort of 3.5 hours out of their blocks.
And that's great, because that's good for the surgery, but not so long that the patient has to deal with a really numb arm for hours.
No, exactly.
Things as well.
One of the consistent things that if you speak to patients who've had blocks before, that they don't particularly like is having a numb arm for a long period of time.
Yeah.
And we've all been guilty. Historically, we're very guilty of that. Everyone got a long-acting agent, and they have a numb arm that they can't do anything with. And if they don't like the sensation, it's particularly distressing. So we can get around that by then targeting things more distally, which will hopefully negate that sort of numb arm sensation. They can safely weight bear their arm and move it around, get dressed and things like that.
I think we're going to just pause there, having done that part, and look at Slido to see if there's been any.
And we have. We do have a question. What dilution adrenaline do you use with the 1%? So, yep, so that's a good question. So you can, I normally use 1 in 400,000 adrenaline. So to make that up, to make up 1 in 200,000, which is the conventional mix, you would add 1 ml of adrenaline to 20 ml of local. So I would add 0.5 ml. But I prefer not to mix, so I tend to use the pre-filled bottles. So they come as either a 1% with adrenaline, 1 in 200,000, or a 2% with 1 in 200,000. And I just mix those with plain lignocaine, whichever concentration we've got, to achieve the 1.5% concentration. The advantages of 1 in 400,000 are less systemic absorption of adrenaline for the patient. So I think, just sort of non-scientifically, but I think that sometimes if you inject a lot of adrenaline, you've used 25 mils or so, they can sometimes just get a little bit shaky as you go through into theatre, which is just the adrenaline. It's not last, it's just the adrenaline, and it settles down very, very quickly. So with 1 in 400,000, they seem to get that a bit less. Secondly is people have done studies looking at the effects of adrenaline on neuronal blood flow, and if you use local anaesthetic on a nerve, you reduce its neuronal blood flow by about 50%. And if you then add adrenaline, you kick it down by, well, it's not 50%, probably about 40%, another 40%. So it's down to 20% of its baseline. So that was with 1 in 200,000 adrenaline. They repeated the study with 1 in 400,000, and they found that they didn't get that drop, that second drop. So you get the drop from the local anaesthetic, but you don't get the drop for some strange reason from the adrenaline. So why that's important is, people like diabetics who might have poor nerve blood flow. So potentially it's a risk factor for nerve injury. So we just, it's not serving any purpose. And the effects on duration of action were not any different. And it still enables you to give that same dose. So it just makes it a bit of a no-brainer, really.
Excellent. We've got one other question about when do you first check your blocks efficacy?
Yep. So I do check, but I'm not a great checker. If you consistently, one of the things we used to do when we were using landmark techniques and blocks that were using longer acting agents and they took longer, is we kept checking, and every minute we'd be checking, and everyone would just get paranoid that nothing was working, including the patient. So I check that local anaesthetic is working, and so I've got a very quick, simple testing regime which we show on Max. So Max, I like to just isolate the biceps, and I say, right, can you bend your arm up towards me? So you're testing just pure biceps function. So having put local anaesthetic around the musculocutaneous nerve to start off with, we know if local anaesthetic is working in this patient, okay, then it should be working now, and I should be seeing that biceps muscle is being weak, is getting weak. Then I do the same with the triceps. So I just get him to bend his arm up, just bend your arm up, and I put his arm like that, and I just push my hand away slightly and just say, right, push my arm away. And now you have to be a bit careful here, because a lot of the times the elbow, the shoulder comes into play, and they try and push you away using their shoulder. But you just by just moving my hand away, it gets them just to use their triceps a bit more. So that's testing radial nerve function. Then I get them just to try and squeeze my fingers together, and that's testing median. Almost certainly, no matter what you've done to whom, they will have some function left in their median nerve, because it takes a lot longer to block than the other nerves. Don't really know why. My kind of non-scientific, well, pseudo-scientific basis is that because the median nerve has contributions from the lateral cord and the medial cord, maybe it's just a bit more myelinated proximally, and therefore the locals test taking longer to get into it. And it's a bigger nerve, I don't know. But it does always seem to take more time, and it can get you worried. But if you know the locals, if you surrounded it up here and the locals working elsewhere, then hopefully it will block in time. And then it's just a pinch in the ulnar nerve distribution, just on the medial border. So it's pull, push, pinch, pinch is the motto. And it's crude enough to work, just to check. And then I don't really test it after that, to be honest. I don't wait. I do my block. I check that, and generally, within, this is all sort of probably 10 minutes from when you've started doing things, there's something happening. And then I know that locals are starting to work, and I take them in. And then you've got time, because there's invariably all the checks, the who and positioning and all the rest of it, waiting for surgeons, etc. So there's generally time for the rest of the block to cook. And we've got I've done distals, so I would have done my distal blocks as well. So they will have covered the operative site. So I'm not really too worried. So I think patients seem to be really fascinated by the fact that bicep doesn't work. And then so that's a really good point. So it's a bit of theatre, really. This biceps check, is the bit where they get convinced. So they've really not trusted you. They've gone through, they're worried they're going to feel things, and when they realise they can't move their arm, it is a very important moment, because they then basically realise that you weren't just making it all up. Or at least you got lucky with that particular one. But skill. So so that's worth doing. Excellent. I think we'll move on, just conscious of time, to the sort of distal blocks now, and your analgesic blocks. So these would be blocks that you could perform if the patient didn't want to have an awake procedure. So they could still have the analgesic block element to this. They just wouldn't have the anaesthetic block up there. Absolutely. So there are three principal nerves we're going to talk about: the median, radial, and the ulnar. And then we'll also just look at the cutaneous nerves, because they're actually quite easy to block. The thing is that makes life a bit more difficult is the anatomy. So we need to think about what operation we're doing as to where we're going to block these nerves. So as a general principle, you want to block more distally if possible to maintain function, motor function, but there are some considerations. So I broadly divide things as to whether surgery is proximal or distal to the carpo-metacarpal junction, and that's going to be something we'll just talk about with relationship to the median nerve and the radial nerve. And it's because they both give off a branch, which a deep branch or an interossseous branch, which innervates the wrist joint, and which more distal approaches will miss. So if we start with the median, when we're stood like this, I want to block the median proximal to the elbow, or at or proximal to the elbow, because at the elbow is where this anterior interosseous branch comes off, which is going to innervate the wrist joint. So for wrist surgery, scaphoids, trapeziectomies, those sort of things, I'm wanting to be more proximal. It would be, you can block it where it's just where we are, where the median nerve is medial to the brachial artery, so we can see the brachial artery here, and we can see the median nerve just to the side here. But with how that's orientated, I would have to be needling back on myself, stood like this. So if you can just see, that's obviously not ergonomic. I mean, it can be done, but it's not ideal. So better to come more proximally in sort of mid-humeral level. So the median nerve sits on top of the artery. We saw it there before, and we can follow it down the arm. And as we come down the arm, at some point, the median nerve is going to move from being lateral, so superior lateral, to being on the medial side. It's just done that now. So, and then it's stays medial. So because I'm stood lateral, I want to block it proximal to here so that I can get my needle around the nerve safely. So I am roughly sort of in the distal third of the arm at this point, but it will vary because that split over to the other side can happen at any point, and it might be that it happens much nearer the axilla. So this is ideal because the artery is below, and I've got a bit of space, so I can come in from laterally, and I'd bring my needle in from over here. And again, I'm wanting to get around. I'll probably bring some local in over the top first, just to try and get into this fascial plane, and then hydrodissect round. You've got to be really careful coming between these two structures, you know, and you want a really light scanning pressure so that the median nerve can move out of the way of your needle. So just be really careful with that. It's someone else's nervous system. You've got to be really careful not to cause a nerve injury. But we're aiming to get a good spread of local anaesthetic that's well circumscribed around the median nerve here. So this will be our approach for surgery proximal to the carpometacarpal junction. If we then come a bit further, there are a number of go-to places where we can just put our probe on and block the arm. We can trace it down and we can follow it, and it's all very nice to be able to do that, but it's not really practical to do that in the middle of a list. So what I like to do with the forearm is to split it into thirds, okay? And for the median nerve, I go at the junction between the proximal 2/3 and the distal 1/3, and I can just put my probe here, and in the center of the screen here is our median nerve, and you can just see this little hyperechoic structure sat here. In between two muscles, we've got flexor digitorum superficialis above and flexor digitorum profundus below. And again, we would block this by, I'm coming from laterally, so I would need to be wary of this radial artery, which is here, and either bring my needle below it or very carefully above it, just bearing in mind that the superficial branch of the radial nerve normally lives over here, so you don't harpoon that.
Yeah. And
then we are coming down to come through this fascia here tangentially, so we're not going to impale the nerve, and then I bring my tip of my needle back up gently and hydrodissect in to get around this space here. So this distal median nerve block would block the lateral 3.5 fingers. Okay, Sam, you've got the camera. So the lateral 3.5 fingers. Okay, and so distal block here would be for something like a Dupuytren's or hand surgery, ORIFs, that sort of thing. Okay, so just as the median nerve has two places, the radial nerve does too, and so we're going to just flex Sam's arm up like this across his chest. Now the radial nerve we saw, we said it sat on the conjoint tendon, and as it goes beyond the conjoint tendon, it drops down and goes round the back of the spiral groove of the humerus to re-emerge on the anterolateral side of the distal arm. So as a kind of overview of where to put your needle, again, if you just take the whole of the proximal arm, split it into thirds, I'm going to go sort of between 2/3 and 1/3 on the distal part of the arm, slightly anterolateral. Just need to put a bit more depth on. So there's a bit more lateral here. So we've got the humerus here. This is all triceps muscle. This is all biceps. And we've got a couple of hypoechoic structures you can see. Okay. There's one here and there's one here. And if we scan proximally, you can see that they both join together, and I'm now scanning around the back of the arm. They are in the spiral groove of the humerus. So if I follow them anterolaterally, this is the radial nerve that is coming out, and it's just sat above the humerus here. Okay, so that's where we would block it, and we would come in. You can come in from either side, but the most ergonomic is to come in with my needle from behind, and be coming in here. And again, you can see how that radial nerve is just in sort of between different muscle bellies, and you're going to come in and come through past here, and again, sort of 3 to 5 mils of local anaesthetic around that. If we come back up the arm, and if I just put the Doppler on, hopefully this is going to work. If you see that little pulsatile structure, which was the other structure that I showed you, that's the profunda brachii artery, which runs in the spiral groove of the humerus with the radial nerve. So again, just don't get confused by that, and that will stay posterior, and the radial nerve will move anterolateral.
Yes, that's a great thing about ultrasound, is that we can see all these things now.
So that's a proximal approach to the radial nerve, and again, if you take that for surgery proximal to the carpometacarpal junction, then that's a good rule of thumb. So distal radial fractures, trapeziectomies, any sort of wrist type work. But we can also block the superficial branch of the radial nerve, which is, so if we scan this radial nerve here distally, we can see that it splits into 2 branches, a superficial and a deep, and it is elongating at this point. The joys of live scanning, will this work? So you can see in the center of the screen, radial nerve, sort of 2 components there, and it's splitting at this point. So there's a branch up here, and there's a branch here, and the branch here is going to dive down out of the way. That's the posterointerosseous branch. And then there is a superficial branch which runs towards the radial artery underneath brachioradialis muscle. And you can see here, this muscle up here is brachioradialis. Here's our artery, and it's this structure here, which is the superficial branch of the radial nerve, which, as we scan distally, runs down towards the radial artery and runs just on the lateral aspect of the artery.
Sam, can you just show everyone exactly where that ultrasound was positioned on the forearm, please?
So you can see what this is a zone we're scanning in. So if we were to go to a go-to place to block the superficial branch of the radial nerve, again, roughly, crudely split the forearm into thirds, 1/3 and 2/3. Put your probe on the anterolateral forearm, get this view of brachioradialis, and then we'll see the radial artery, and then we're looking for a little hyperechoic structure that runs towards the artery, and you can block it at any point there. This would be quite a nice place to block it. It's quite obvious there, and it's in a little pocket there, just of that fascia around it. So again, that is for hand surgery. It will cover the cutaneous innervation of the back of the hand. The ulnar nerve, fortuitously, doesn't have any branches we have to worry, or significant branches we have to worry about. And so we can tackle that in the forearm, in the proximal forearm. So it's a bit difficult to follow in the upper arm because it doesn't have any nearby vascular structures. It runs quite a subcutaneous course in the upper arm. And so there's nothing to necessarily easily pinpoint it. Then it goes around the ulnar, in the ulnar groove. And again, this is a bony, hard bony landmark which we can't image very well. You can you may be able to see just here at the top of the screen, in the center of the screen now, just the ulnar nerve in this here, but it's not a great view. And then as we come down, we come into the forearm. So I'm going to go, again, simple go-to place, 1/3, 2/3, so the reverse of where we were for the median. And I'm going to put my probe strictly vertical like this, on, so that the base of the probe is flat on the table. And this will give me this view, and it's a really consistent view all the time. So the ulnar nerve is almost always underneath flexor carpi ulnaris, which is this muscle up here. So this is the belly of flexor carpi ulnaris, and here is our ulnar nerve here. Okay, and this will be FDS, and this will be FTP. And so we can approach it by dropping in from the top, which would be coming in like this. And again, we'd come to the corner here, get into the space around it, hydrodissect our way around. So there's only one place to remember for the ulnar nerve, which is makes life quite easy. Why we put our probe like that, and I kind of very didactic about teaching that, and everyone comes and puts their probe flat, is if you put your probe like this across the top of the arm, okay, you can now see two nerves in that screen. Okay, to the left here we have the ulnar nerve, okay, and then over here we have the median nerve. And you know, this muscle could be a bit like flexor carpi ulnaris there,
Yeah.
and you can get confused. And so don't get confused, just make life simple, keep it like that, and you won't ever go wrong.
Something I found when the patient's arm starts getting numb is the hand starts going across, so it's
Yep.
something to
Yeah,
just watch
sometimes
out.
just
Some
a piece of
people
tape
can-
across the arm, or
Yeah.
just put someone to hold it. And then lastly, I think we're on to the cutaneous nerves.
Yep.
Everyone's like breathing a sigh of relief, not least me. So these are really easy. So we've got the median cutaneous nerve of the forearm, and we're going to block that in the proximal, the distal arm here, just on the medial side. Really light probe pressure, because they have a vascular structure that they run with. So in the center of the screen here, you can see this compressible basilic vein. Okay, that's our basilic vein that we might well try and put a long line in. And then on the either side of it, so if we just put the depth right down, that's probably the best view. You can just see it in this little corner here and over here, there are two hyperechoic structures. And they are both the terminal branches of the median cutaneous nerve of the forearm. Okay, if you were to track them back up, they may well become one structure. I'm just tracking them back up now. It's just over the top at the moment. But basically, we're just going to pop our needle in from over here, from the right side of the screen, and just do a perivenous injection around to catch those two little branches. And you can just need to be a bit careful about how you come over the top of the vein or underneath the vein to get to either side. So only a couple of mils of local anaesthetic to block those, and that will provide cutaneous coverage of the forearm. And last but not least is the lateral cutaneous nerve of the forearm, which also has a vascular landmark. So here we have I'm in the antecubital fossa. In the center of this, we've got our brachial artery over medially. In the center of the screen, we've got a biceps tendon, and then we've got a cephalic vein over to in the center of the screen now. Now, I don't know if this is going to show up very well at home because of the gain, but if I compress that vein, there is a white hyperechoic structure underneath the vein here, which persists even if I compress it. So it's not post-cystic enhancement. And that is the lateral cutaneous nerve of the forearm. It's best I can see it nicely there, but I can appreciate it's probably a little bit of the eye of faith at home. But there's this structure here. So we would be coming in from laterally, just bringing our needle into here, and again a couple of mils of local anaesthetic. Once you get in around it, it brightly highlights up. It often has comes to quite elliptical, kind of long shaped structure once you put local anaesthetic around it. And so that's going to give us our lateral forearm cutaneous coverage.
Great, thank you. So how we've gone in, we've talked about testing, and we've got lots of time, the block is working. And I think some of the surgeons don't tend to say, does this hurt or anything? How do you manage that if you have a patient who's anxious, thinks they can feel something?
Yeah.
What do you do with sedation or no sedation?
Sure. So first of all, controlling expectation from the start. So I do tell them they will feel touch.
Yeah.
And that's normal, and that touch doesn't translate into it feeling pain, because invariably as soon as they start to prep the arm, they go, I can feel that.
Yeah.
And the seeds of doubt are sown, and they think you've sold them a lie. So first of all, warn them. Secondly, sedation is a difficult subject, really. First of all, a lot of people, and you see charts from people who've had a block, an awake block before. They've basically had a GA without an airway on a propofol infusion with a TCI of 2 and a block, and that hasn't really served a huge purpose. It's not meant to be an ordeal for the patient, but if your block's working fine, they should be able to tolerate it without that level of sedation.
Yeah.
So some people need some anxiolysis, so that, you know, a couple of midas or whatever at the start, that can often work well for that. I'm not a huge fan anymore. I've done it, but not a huge fan anymore of running propofol, so that to the point that which they fall asleep, because invariably they will wake up at the start or just get obstruct their airway, and it becomes more of a nightmare. And you're losing, if you've given them heavy sedation throughout, then they're losing the advantage of being able to go through to the next stage as well.
Yeah.
So if that's the only way they'll have it, that probably wasn't the right technique for them up front. But sedation can help. So if the block is not working 100%, then sometimes you have to be pragmatic and you have to start things. It's not an ordeal. The surgeons can top up. If we were to have access distally, we might be able to top up an area if we've missed it. And you can, again, the mid-humeral level is quite a good one for getting to everything. But you know, and ultimately you're just going to bail out and get them off to sleep if it's really not working. But you can have what looks like a well-working block, and there's sometimes just this one bit that they get to that's right deep down, and you know, often just some surgical local will sort that out. It depends on the procedure.
Any particular type of surgical local you'd recommend? Is it lignocaine, so it's faster?
I mean, generally they've got long-acting drawn up, or they might have long-acting drawn up anyway. But you know, we've used quite a lot of lignocaine. It depends what you've got left, but anything, it all works quite quickly. Some people reckon bupivacaine works almost as quickly as lignocaine. So some people, you know, say that on sensory nerves. So yeah, just use what you've got available.
Great.
Or you know, a little bit of fentanyl, something like that to get them through it. You know, just to be sensible. It's the same with the tourniquet, really. You know, so tourniquet, we haven't mentioned in huge detail, but so tourniquet pain, there's two kinds really. There's the sort of the classic kind of tourniquet pain is this late type, which comes on after a period of time. They get an achy arm, and it just ramps up. Their blood pressure goes up. And it's really sort of due to muscle ischemia. Probably we don't really know what it's due to, but it will break through your block after generally sort of at 75 minutes or so, and some people either get it or they don't. But once you've got it, it's pretty hard to get rid of. The other sort is this sort of early, a bit like blood pressure. You know, there's certain patients who, when you put the blood pressure cuff on, they hit the roof. The ones that make my heart sink for doing axillary brachial plexus blocks, because they almost certainly will get that initial early tourniquet pain. And so you need to block those cutaneous nerves, and that is probably due to you know, it's a pinching type pain, which is probably due to the cutaneous nerves not being covered. In terms of which brachial plexus approach, there's precious little difference between approaches, because they will all block the muscles and the main nerves of the arm equally. We can approach separately the cutaneous nerves, but the things to do are to, first of all, try to prevent this by not having the tourniquet pressure super sky high. So often they're put a lot higher than they need to be. So 250 as a default isn't necessary. You can use different techniques. You can look at the limb occlusion pressure, which in the real world as very few people actually measure, and then add 60, or you can use the systolic as a guide, and then I'd say add a bit, not typically 80 has been described. Or we can block, and for the early pain, we can block these cutaneous nerves. This group compared, those are the little nerves that I showed in the tail of the axilla, and with ultrasound guidance compared to a sausage of local across the proximal axilla. Certainly ultrasound guidance seemed to be far more effective at blocking the cutaneous coverage, and resulted in a higher degree of tourniquet comfort. But you know, don't kid yourselves, that is only going to affect the skin nerves. It's not going to stop that late onset ischemic pain.
Great. I think we'll just go to see if there are any more questions. Okay. This is a really great session. Will you be recording the sessions and making them available more widely? And will recommend the rest of my department. Thank you.
So yes, there will be a recording, hopefully, if it's not too embarrassing. And we will, if you've so here's the thing: if you fill in the feedback, the post-course feedback, which we'll email you, you will get access to the recording. Do all patients receiving regional anaesthesia with or without sedation go to a dedicated recovery area after the block is performed? Thank you. So I think it depends on your local preferences and practices. So as I said at the start, one of the things we try and sell to patients is the benefits. So we can cut out at least 25 minutes, if not more, time of them sat having blood pressures. I've just watched their blood pressure for two hours. No one needs to do it for any longer, really. So they go bypass the first stage recovery, go to second stage recovery. I take all of the monitors off to take them round, providing everything is fine. To sit them up first, just to make sure they're not going to collapse on you. But otherwise, they will be monitored. If you take them around with a load of monitors on, nurses, and no offence, like to monitor and to write things down, and they will chart some more blood pressures forever. And the patient won't go home, and an hour later, you'll go back to see them, and they're still sat there hooked up. So I take them out, provided they haven't had sedation or any more sedation than maybe just a couple of midas, an hour ago at the start of the block. So that's our kind of local rules.
And we've got another question: is does the anaesthetist remain in theatre, or do you send the patient into theatre and then proceed with the next block?
So we are always immediately available. I'm usually in theatre. I don't think it's really a good look for us to go and sit in the copy room whilst the patient's having a block without us there. If, however, we've got another patient to block and the patient on the table is stable and the block is working and tested and there's no issues, then provided there's someone to look after that patient, which can be anyone from an ODP to a nurse who can, I'm only the other side of an anaesthetic room door. So we will then get on with the next block to get the next one ready. And that's where you get those efficiencies. So we don't have a block room. Block rooms are a whole different debate. If you've got a block room, it doesn't really matter, but we use anaesthetic rooms and it works well, and you don't need to have a block room. But you do just need to be able to do that. So you've got to have someone that can talk to the patient and just keep an eye on them. And we're just literally the other side of a door. So we can leave it, if I was in the middle of a block and there was something happening in there, I can leave that. I can leave that and come back to it. Yeah. It's not the end of the world. This patient is awake. This patient's not sedated or anything. So I think we're.
There's one other thing that we have done is we've used AV.
Yeah, that's a really good point, Joe. So AV distraction. So there's a lot of interest in that now, just as an alternative to sedation. So there was a paper about 5 years ago called Music versus Midazolam, and they found that it was as effective as intravenous midazolam for sedation during case. Here we have in most of the areas where we do awake blocks, we've got some iPads and some headphones. If you know your patients are going to be awake, you can tell them to bring their own headphones and a phone in. I think it's a good idea because they're focusing on your experience. You're going to suddenly think, oh, is that tourniquet a bit tight? What's that you said about the tourniquet? Exactly. That's a bit tight in my arm. So if they're just not thinking about it, then I think you get a bit longer on tourniquet coverage. And it's a long time to lie there. It's not, and there's only so much chat we all have in us. I do chat to my patients most of the time, but sometimes we have days where we're not feeling terribly chatty, and so it stops those awkward silences, and it's a benefit. So SOWRA has now, so all hospitals in the southwest region, so Exeter, Torbay, Taunton, Truro, and here in Plymouth have all now had a grant for some AV equipment, so they should all be appearing in your departments around the region to be used to help facilitate awake surgery.
Had a lady singing the Eagles soundtrack out loud.
Yeah, no, it happens.
It's lovely. And then one last question from me was, so for anaesthetists who are newer to the awake hand surgery, what advice would you give? Is there anything you'd say, sort of starting out, how they're going to do it?
Give yourself time. Okay, so that's the most important thing, because you're going to be slower when you're first starting out. So get everything ready in advance, get all your drugs drawn up, get your probe covers on, you don't want to be doing all of that out of your block time. Send nice and early. If you can overlap cases when there's a local on the table or whatever, do that. Pick winners. Don't try and convince someone who is not dead set against it. often patients have had this before, so they'll be willing to have it again. And trust yourself. You know, if you don't do it, you'll never get good at it. You've got to step over that hurdle at some point and get someone along. You know, most departments, I'd like to think, it's certainly in the Southwest, have friendly enough, approachable enough people that are enthusiastic, want to see you succeed, that they'll come and watch you do a block, and you know, and then you'll just get more confident. So bring a friend in to watch you, yeah, just dive in. And with the distal blocks as well, you're buying yourself that extra bit of time and security in that even if your proximal block wasn't 100%, your distal block should get you through things.
Great, thank you very much.
Thank you.
Thank you all for joining and listening. We will be sending a post questionnaire just to see if you found it useful, what we could improve, etc., etc. You see on the website that there'll be the next webinar, which you will come and talk about knees, is due in a few months' time. And then we've got the SOWRA course a couple of times a year, so if you'd like to learn and come and scan, then look out for the dates that they are out. Anything else?
I think we covered everything. I'm out of talk.
Thank you very much. See you all next time.